What is urinary retention? Urinary retention is the inability to empty the bladder completely or at all despite a full bladder. It is an emergency because prolonged obstruction can lead to acute kidney injury, bladder overdistension, hydronephrosis, infection and sepsis. Bladder muscle injury. Types. Acute urinary intention. Its types include acute urinary retention and chronic urinary retention. Acute urinary retention. Its causes is sudden inability to pass urine. Severe suprapubic pain will be there. The bladder will be distended. Restlessness will be there, and it is medical emergency. Chronic urinary retention. Long-standing incomplete bladder emptying. In it, there will be overflow dribbling. There will be little pain and large residual urine volume. Causes. Remember obstruct. Obstructed causes includes benign prostatic hyperplasia, most common in elderly men, urethral stricture, bladder tone, blood clot, tumor, that is prostate or bladder, severe constipation, compressing urethra, infection or inflammatory. This includes prostatitis, urethritis, cystitis, genital herpes causing painful voiding. Neurological causes includes spinal cord injury, cauda equina syndrome, multiple sclerosis, diabetic neuropathy, stroke. Medications. Give anticholinergic medications that causes urinary retention includes anticholinergics, tricyclic, antidepressants, antihistamines, opioids, sympathomimetics. Postoperative, when there is general anesthesia or epidural anesthesia given, it also causes urinary retention. Symptoms of urinary retention. Patient cannot pass urine, severe suprapubic pain, distended bladder, urgency, sweating, restlessness, overflow, dribbling. If infection, then there will be fever, chills, dysuria, and confusion in elderly patient. What is the best ER approach? A, B, C, D, E. A. Airway, assess and secure if required. B. Breathing. In breathing, check respiratory rate, oxygen saturation, give oxygen if hypoxic. C. For circulation, check blood pressure, pulse, IV access, ECG if hyperkalemia suspected, fluid assessment. If septic, IV crystalloids, that is 30 ml per kg if septic shock. Blood cultures before antibiotics if possible. Disability. Assess GCS, blood glucose, look for sepsis related confusion, check lower limb weakness or saddle anesthesia. That is cauda equina syndrome. E. Exposure. Examine abdomen, suprapubic fullness, costovertebral angle tenderness, external genitalia, perineum. Focused history. Ask what is the last time urine passed. Ask about pain, fever, dysuria, hematuria, flank pain, weak stream, dribbling, previous catheter, history of benign prostatic hyperplasia, any kidney stones, recent surgery, neurological diseases, or medication history. Check examinations. On general examination, there will be fever, tachycardia, hypotension, signs of sepsis. Abdominal examination. There will be distended bladder, tender suprapubic swelling. On genital, check for phimosis, urethral injury, blood at meatus. Rectal examination. Enlarged prostate, tender prostate, acute prostatitis, hard irregular prostate, possible malignancy. Neurological examination, lower limb power, reflexes, sensation, and anal tone. Investigations at bedside do bladder scan post-void residual, ECG if hyperkalemia suspected. Blood test includes CBC, CRP, urea crete, electrolytes, blood glucose, lactate, and blood culture if febrile. Urine includes urinalysis, urine microscopy, urine culture. Imaging includes ultrasound kidneys, ureter, and bladder. CTKUB if stone suspected. MRI spine if cauda equina suspected. First line management. Pass Foley's catheter insertion, usually 14 to 16 Francium Foley's. Use lidocaine gel. Document ease of insertion, urine color, volume drained. What if Foley's catheter is inserted but no urine comes out? This is very important emergency scenario. Step 1. Check catheter position. The commonest reason is the catheter in is not actually in the bladder. Check balloon inflated too early. Catheter inserted far enough. Gently advance further if appropriate. Irrigate with sterile saline to assess the patency. Step 2. Catheter blockage may be blocked by blood clot, debris, pus. Management. Irrigate urgently with sterile saline. Replace catheter if blocked. Step 3. If the bladder actually full, perform bladder scan. If bladder scan shows less than 100 ml, the patient may not have urinary retention. Think AKI, dehydration, septic shock, and urea. If the bladder scan shows greater than 500 ml, retention is likely. Try reposition catheter, replace with another Foley. Consider a cord catheter, especially in BPH. Seek urology review if unsuccessful. Step 4. Could this be anuria rather than retention? This is the key differential. Retention is equal to urine is produced but cannot exit. Anuria is equal to kidneys are not producing urine. Cause includes septic shock, severe dehydration, bilateral ureteric obstruction, acute renal failure. Ultrasound kidneys. Look for hydronephrosis, distended bladder, or empty bladder. What if the patient has fever? Now think beyond simple urinary retention. Fever plus retention suggests acute bacterial prostatitis, polynephritis, urosepsis, obstructed infected kidney, pyonephrosis, perinephric abscess. Management of febrile urinary retention. Treat as soon as possible urosepsis until proven otherwise. Sepsis bundle. IV access, blood cultures, send urine culture, send lactate, IV fluids, give IV antibiotics early, monitor urine output hourly, consider vasopressors if shock persists despite fluids. Use antibiotics according to the local hospital guidelines and cultures results. Empiric therapy should cover like urinary pathogens. When not to force a polycatheter, avoid repeated forceful attempts if blood at urethral meatus, pelvic fracture, suspected urethral injury, severe urethral stricture. In these situations, retrograde urethrogram if indicated. Urology consultation. Consider suprapubic catheter if possible. Differential diagnosis of no urine after Foley's. 1. Catheter misplaced. 2. Catheter blocked. 3. Balloon inflated in the urethra. 4. Empty bladder. 5. Severe dehydration. 6. Acute kidney injury. 7. Septic shock with inuria. 8. Bilateral ureteric obstruction. 9. Ruptured bladder, usually after trauma. 10. Urethral injury. 11. Acute bacterial prostatitis. 12. Obstructed infected kidney. Red flag requiring urgent urology review. 1. Failed catheterization. When to inform the urology? When there is failed catheterization, gross hematuria with clots, suspected urethral injury, obstructive AKI, hydronephrosis, urosepsis, obstructed infected kidney, persistent anuria despite correct catheter placement. Example ER case, a 68 years old man present with inability to pass urine for 12 hours, fever that is 39 degrees centigrade, suprapubic pain, heart rate 120 per minute. Blood pressure is 90 by 92 by 58 mmHg. A Foley's catheter is inserted but no urine passed. Approach: reassess the catheter placement and irrigate to check the patency. Perform a bladder scan. If the bladder is empty, consider anuria due to sepsis or AKI rather than retention. Send CBC, renal function test, electrolytes, CRP, lactates, blood cultures, and urine studies. Start IV fluids, obtain culture, and administer empiric IV antibiotics according to the local guidelines. Perform renal and bladder ultrasound to look for hydronephrosis or obstruction. If imaging shows an obstructed infected kidney, for example, hydronephrosis with sepsis, this is urological emergency requiring urgent decompression such as ureteric stenting or percutaneous nephrostomy in addition to antibiotics. Key pulse exams. Painful distended bladder is equal to thin acute urinary retention. Foley is inserted but no urine. Do not immediately assume catheter failure. Check catheterization position, patency, and bladder volume. Empty bladder plus no urine. Think anuria, not retention. Fever plus retention. Then suspect acute prostatitis or urosepsis. Fever plus hydronephrosis treat as an obstructed infected kidney, which requires urgent urological intervention as well as antibiotics. Always monitor urine output closely after catheterization and assess for obstructed post-obstructive diuresis if a large volume of urine is drained.